And here is today's agenda. We're going to start off with remarks from Aditya from the International Network of People Who Use Drugs. We're then going to move on to a presentation from John Kimani of KeNPUD, the Kenyan Network of People Who Use Drugs. Following that, from Johns Hopkins University, we have Dr. Sunil Solomon. And finally, we're delighted to have a provider from Ukraine, Dr. Tatiana Kaliva, who will be sharing some perspectives from her clinic and her context. So without further ado, I am going to stop sharing my screen. And has Aditya joined us yet? Aditya, are you here? Okay, I'm going to check on what's happening with Aditya, and we're going to move on to our next speaker. So John Kimani with KeNPUD. I'm going to invite you to share your slides. Oh, go on video if you can, and share your slides and start your presentation if you are ready to do that. Are we good, John?
Yeah, we're good. Well, I had shared earlier my presentation. Maybe you can.
John, do you want me to share your slides for you?
Yes, please.
Okay.
I really appreciate that.
That is no problem whatsoever. Just give me 1 second, and then you just let me know when to advance.
Okay.
John, are you seeing these okay?
Yes, actually, it's great. It's okay. So maybe if I can go straight to the presentation. Well, good afternoon, good evening, good morning, and good day to all. Thank you for joining this webinar, which the topic is really important amongst people who use drugs. I'm happy to be part of this discussion. So my name is John Kimani. I work with the Kenya Network of People Who Use Drugs in Kenya, which advocates for the human rights of people who use drugs and their rights to comprehensive and also quality healthcare services without stigma and discrimination. So I'll go straight to my presentation. Next slide. So KeNPUD is a national network of people who use drugs. It has county networks, grassroots groups, CBOs, affiliates. It was founded back in 2012. KeNPUD is dedicated in advocating for prevention interventions on HIV, including harm reduction services for all drug users in Kenya. Our community-led involvement, different Maskani officers, these are hotspots representatives, peer educators and navigators, outreach workers. Our work is donor dependent. Actually, we depend on funding from well-wishers and donors. Our next slide. So what guides us is a vision that we had: empowered drug user and just society. Our mission is to improve the well-being of people who use and inject drugs through grassroots organization of people who use drugs. Next slide. When we come to prevention, and as we are discussing this issue of PrEP amongst people who use drugs, we have seen that through the different size estimates and research that has been done, you'll find that there is high HIV prevalence over 18% high level of risky injection practices, sharing injecting equipment. And this also is happening a lot to those occasional people who inject drugs, because mostly you find that maybe they are not in a position to inject themselves. So they share with the people who already inject on daily basis. So we have lower perception of HIV risk, lack of specific data on young people and women who inject and use drugs. We also have poor access to HIV prevention services because of stigma and discrimination. And this is mostly in the government facilities, whereby you find that for those nurses or doctors that are not sensitized or have no information on what is harm reduction, or people who use drugs, you find that we face a lot of stigma and discrimination. We also get harassment, unable to negotiate for sex, and stigma. So you find through this, we are in a bigger risk of being able to be infected by HIV. So PrEP uptake among people or women who use and inject drugs, it is low, because there hasn't been a lot of concentration amongst women who inject and use drugs, because I think first it came with the female sex workers organization, who were early well sensitized. But as we have moved on, we have been able also to be involved in this process. And I know our women are able to access these services, which also we've been advocating that they should be in the grassroots organization, and also in the MAT clinics as a one-stop shop. So needles and syringes are other harm reduction intervention prioritized, and supportive laws that criminalize drug use in Kenya. Intersectionality among people who inject, that increased need. Next slide. Okay, so PrEP. PrEP in Kenya, when you look at the 8th strategic framework of 2021 to 2024, HIV prevention revolution roadmap in Kenya, facing and heading to 2030, recommends that PrEP for people who inject drugs and other key population, recommends differentiated services delivery for HIV prevention interventions. However, high concerns among people who inject drugs on effect of using many medications and polydrug use to vital organs like kidney and liver failure functions. And this has been seen widely because of the new drug that is it has really hit the market. And this is cocaine crack. And there's a lot of sharing, and which is we have a risk of being affected by or transmission of tuberculosis. And also you find that there will be lungs problem. uh, well, community knowledge on PrEP, HIV risk, needs, preference on interest for PrEP is very low. Actually, it is low because you find that people who inject drugs, maybe this information has not well been packaged to reach them, or for them to be able to understand it. Okay, we have low demand of PrEP among people who use drugs, because actually you find that women who use drugs, it's not all of them who are sex workers. And you find that their involvement in sex work, it is minimal. And some have other ways of hustling. So I can say it is low, there is low demand on PrEP among us. But as we continue, I think the young people who use drugs, or the young injecting drug users, that is where we need also to put our concentration as they continue growing. We can be able to educate them. Many people who use drugs are socially not available and remain in hiding and marginalized. Why are they marginalized? They are marginalized because of the physical appearance. They are marginalized because they are seen as a curse in the community. They are marginalized because and criminalized because the way they hustle, their way of looking for money for their next fix. You find that sometimes people indulge in criminal activities, and this is where you find that we are told that it's a hidden community. It's not really hidden, it's only that the laws, policies, perception of our communities and families are the ones that have pushed us into hiding. Next slide. What we have done so far, continued implementing a Maskani model from grassroots. Like I told you earlier, the Maskani model, these are hotspot representatives from grassroots. Continue advocating for harm reduction services access. Take advantage of devolved system, continue empowering people who use drugs leadership at grassroots to occupy decision-making spaces around harm reduction interventions. And on this, continue collaborating with KPs, government agencies, and development partners in advocating for people who use drugs and access to life-saving services. Well, I would like to tell you that we have seen a lot of support from our own government that has been in the forefront to make sure that we get these services and that prevention is at the top of the agenda. Next slide. Challenges that we are facing. Well, there is limited funding, which brings up a very huge gap in our continued advocacy work. We have limited access to needles and syringes by people who use and inject drugs in some counties, whereby we don't have dropping centers, or we don't have methadone clinics. Something else is an affordable travel cost a long distance to access HIV prevention services, including harm reduction interventions. And this is what I stated earlier, that you find in some counties, we don't have like a methadone clinic. So getting some services, it becomes a challenge. And also if there is no dropping center and there are no outreach workers to reach out to those communities, you find that they are not able to access the harm reduction interventions. Stigma and discrimination is still high, needs continuous addressing, and we've been working with the county and the national government to make sure that we sensitize doctors, nurses, and the healthcare workers in general on stigma and discrimination among people who inject drugs. Inadequate research and minimal involvement of people who use drugs in designing a suitable community interventions to improve reach. Next slide, Jim. Well, that was my last slide. And I know and believe that nice people take drugs. I'm a good person, I'm a nice person, and I've been taking drugs for the past 25 years. And with this information, I hope that people will be able to join us in advocating for healthcare services without stigma and discrimination among us people who use drugs. So thank you. And you can check us out or check our work out on our website, www.kenpud.or.ke, Twitter account at KeNPUD1, and also we are on Facebook. So thank you so much for listening. Thank you so much for your time. And over to you, Jim. Thank you.
Thank you so much, John, for that great talk and for kind of jumping ahead of our plans. We are still looking for Aditya, and we will bring them on when we are able
That is
to.
Bapa's flower.
I want to just take a quick pause. John, you're getting a lot of
Marigold.
love in the chat for good reason. Is anyone like to ask a question live on camera? Just go ahead and raise your
Yeah,
hand
for Bapa.
if you would like to do that. And I will take, there's a question in the QA for you, John.
Yes, please.
Who is providing support or funding for syringe service programs in your area?
Who is, sorry?
And John, you're on mute.
Who is, sorry, can you repeat that question, Jim?
Did you hear the question, John?
No, please do repeat it.
Okay. We may be having some connectivity issues with John. So we will still have lots of time for Q&A when we are done with these with the presentations. So I'm going to go ahead and move forward and ask Sunil Solomon, Dr. Sunil Solomon with Johns Hopkins, to share his slides and take us through his presentation. We will come back to these questions, no worries. Thank you, Sunil.
Thank you, Jim. Just want to make sure you can see my slides and hear me. Am I audible? I'm guessing I am. Great, I'm gonna go ahead.
Sunil, we cannot hear you.
You cannot?
I can hear Sunil. It's Yanis.
I can hear him too.
Okay, so other people can hear you. For
I
some
can
reason
hear him.
cannot hear you. But I trust that if other people can hear you, I will figure out what's going on with my situation here.
Jim, I'm guessing you've
Go ahead,
heard this
Sunil.
talk before, so you decided not to hear me. But anyways, thank you for the invitation to present here today and for the opportunity. It really is an honor. And thank you, John, for just setting this whole thing in context. So these are my disclosures. I want to just start by trying to lay out why are we having this webinar today and why are we talking about people who inject drugs. I think most of you in this room know, but I think just trying to bring us all onto the same page is probably going to be my first step. So I think as most of you are aware, in the US, we are in the middle of an opioid crisis like we have never seen before. We're breaking records every year. Over like 100,000 Americans died of overdose deaths in 2021. And it's likely like these numbers are going to keep increasing. What also happened was in 2018, it was estimated there were approximately 3.1 million people who inject drugs in the US, which is almost a tripling in the estimate from 2011. So essentially, and it's very likely that this number has grown even higher through the pandemic. The other thing I wanted to point out was in the US, we were seeing decreases in HIV incidence and hepatitis C incidence among people who inject drugs across the country. But what we have been seeing in recent years are like these small outbreaks of HIV among people who inject drugs in multiple parts of the US, especially in rural areas and other regions where we traditionally had not documented epidemics of HIV among people who inject drugs. So it's very likely that with the influx of fentanyl and xylazine and all these synthetic drugs, it's very possible that we will continue to see these outbreaks of HIV among people who inject drugs across the US, even in regions which we really haven't thought of as like traditionally regions where HIV is driven by drug use. And this is not an issue that is restricted to the US, it's global. I think one of the big things that comes out from most reports globally is like estimates of HIV incidence among people who inject drugs globally are limited. But I do have access to some of our data in India, which is actually longitudinal incidence data among cohorts. So we followed 782 HIV negative people between 2017 and 2022 in New Delhi, India. This was in the era of free test and treat, highly active antiretroviral therapy. And we still saw an incidence of 21.3 per 100 person years. And this is extremely high, in my opinion. I think the one estimate that comes close is from Ukraine, but that was a little bit earlier in 2014. So I'm really looking forward to hearing the perspectives from Tatiana from Ukraine as well. The other thing we also do have from India is longitudinal HIV incidence among people who inject drugs who are actually visiting a clinic, either for harm reduction services, either for opioid substitution therapy, or for a syringe service program, or for counseling. And so you can see, even in this group of people who are highly motivated to engage in care, HIV incidence is close to like 20 in some of these settings. And the overall incidence across all these 8 cities that we were working in was about 5 per 100 person years. And I'm talking about incidence among really engaged people and not prevalence. So you can expect prevalence to be like significantly higher compared to incidence. But if you're looking at it globally, it is a very heterogeneous epidemic. And I think John already highlighted the issues with in Africa, with like new epidemics of HIV among people who inject drugs mushrooming across. So in the US, we're about 5 to 10% prevalence, but there are regions in the world where it's almost 40% of people living, people who inject drugs are living with HIV, which is essentially like less than 1 in 3 people has HIV. And again, it's very important to also recognize that while most of our focus is on sub-Saharan Africa, because that's where the majority of people living with HIV reside, about 1 in 5 new infections outside of sub-Saharan Africa are driven by drug use. And so if we really are serious that we want to achieve HIV/AIDS epidemic control or any of those ambitious targets, we really need to include people who inject drugs into our prevention agenda. So I think John already spoke about some of the limitations with access to PrEP among people who inject drugs in Kenya, but let's look at the US. So I think most of you are very familiar with the USPSTF's revised guidelines, which came out earlier this year. And I'm guessing all of you are extremely excited that it's a grade A recommendation for all adolescents and adults at increased risk of HIV, which I think is phenomenal. But I don't know how many of you went through the entire report, because it really is disturbing that no PrEP medications have the FDA approval for the indication of reducing risk of acquiring HIV via injection drug use. But this guidance is based on Centers of Disease guidelines that suggest that they are likely to benefit from PrEP with any FDA-approved medication. So really, this data does not exist. So how do we let this happen? So let me go back to 2 of my studies, which I think are like my all-time favorite prevention studies, because I feel like they really have changed the field. So this is the PrEP seminar. So let's talk about long-acting cabotegravir, HPTN-083, HPTN-084. Really phenomenal, reduced the HIV incidence by 60 and 80% among cisgender men who have sex with men or heterosexual women. Revolutionized the PrEP agenda. And then let's look at HPTN-052, which in my opinion is like the most powerful prevention tool we have to date. Almost 0 transmissions. And this really spurned the entire U is equal to U campaign. So one is a prevention trial, one is a treatment trial, but they do have one thing in common. They both excluded people who inject drugs. So I completely recognize that both these trials really were focused on sexual transmission, so exclusion of people who inject drugs makes complete sense. But I think the one thing we need to remember is we cannot put people in boxes. Heterosexual women or cisgender men who have sex with men also inject drugs. People who inject drugs also have sex. So putting these artificial boxes just makes it much more complicated for us to think about how do we, who is this really relevant to? So if I'm working with MSM or injecting drugs, are the findings of HPTN-083 going to be relevant or not? The same thing applies there as well. And I think what really has to happen as a result is long-acting CAB is not approved for intravenous transmission. And HPTN-052 really has spurned the entire U is equal to U. So your partner, partner 2, opposites attract. And it really has been about sexual transmission. So do I think U is equal to U will not apply to people who inject drugs? Probably not. I think it's going to work. But if you ask me to show you the data that supports my claim, I have nothing. So I think the one thing we need to think about going forward from the research field when we're designing trials is, why are we excluding people who inject or use drugs from this trial? does it make sense to exclude them? And I think that's the question we need to start asking when we're designing these eligibility criteria without just blindly excluding people. So let's start with PrEP. So what do we really need to know about PrEP? I think there are two things we need to know. The first thing is efficacy, which is a function of potency and adherence or compliance to the injections. And the second thing, which is probably the most important thing, is effectiveness. So once we've proved something is efficacious, what is the uptake of that particular agent in the community? So let's start with oral PrEP, which we know based on the CDC recommendations that it probably is going to benefit. There is a recommendation. It is grade A. Theoretically, people who inject drugs who want PrEP should be able to get on PrEP in India, so in the US and in most countries globally. They also are an ideal population because the people who inject drugs have lower levels of HIV viral suppression, so the risk of transmission is higher, and consequently the HIV incidence is higher. If you're looking at it from a cost effectiveness perspective, low viral suppression and high incidence really drives up your cost effectiveness. Like your return on investment from a government or a programmatic standpoint is going to be phenomenal if you are working with people who inject drugs, only because they do have low viral suppression and high incidence. But between 2010 and 2019 in the US, receipt of PrEP among people who inject drugs went from 0 to 0.295 per 100 person years. And we really need to think, like, why is this so bad? And so this brings me to the next part, which is about demand. So I think most of you are familiar with the PrEP for Love and then all the other campaigns. If you do a Google search or remember watching television, most of the commercials or the advertisements are targeting men who have sex with men. So when I have gone out into the communities in Baltimore and talked to people who inject drugs and asked them why you're not interested in PrEP, their answer is like, well, we just thought it was for gay men. Right? So I think that needs to change. We need to have that same kind of demand generation mechanism that targets people who inject drugs to make them recognize that they also have something to benefit from PrEP. And until that happens, we aren't going to see like a big uptake of PrEP among people who inject drugs in the US or globally. And I think John highlighted the same in Kenya, where the knowledge of PrEP really was extremely low among people who inject drugs. So now coming to potency. So if you're looking at long-acting PrEP, so these are data from macaques that were challenged with HIV after getting long-acting CAB. And these are the exact same data from, sorry, the left is an intravenous challenge, the right is an intravaginal challenge. So the right resulted in HPT and 084 being formed, the indication, and the left ended in the left. They actually concluded saying these reports support the clinical investigation of long-acting CAB as a PrEP agent in people who inject drugs. But that result ended with that publication and never translated into a phase 3 trial, never translated into recommendations of long-acting CAB for people who inject drugs. So if we are talking about long-acting CAB in people who inject drugs, what are the things we should be thinking about going forward? So I think the first thing we need to ask ourselves is, what is that definition of long? Is it 1 week? Is it 1 month? Is it 2 months? Is it 6 months? Because I think it depends. And I think trying to have all those different options is critical. For example, if you're looking at India, where people who inject drugs come into an OST center once a week for their medications, it's very, for their MOUD, it's very easy to give them like a weekly 1 tablet pill along with their weekly medications of buprenorphine and naloxone. Similarly, 1 month is what we do in many other countries in the world. 2 months is what CAB is. 6 months is what lenacapavir is. Each of them have their advantages and disadvantages. But I think we need more work to understand what really works and also recognize that one size does not fit all. We probably need all. I think this gets very tricky because with long-acting injectables or oral medications, once it is in your system, we cannot get it out of your system until it plays out its natural pharmacokinetic role. So for example, if there is a potential for drug-drug interaction with either like substances of misuse, which keep changing, like we had fentanyl, we have xylazine, we have benzodiazepines, we have cocaine, we have amphetamines, and that just keeps changing. And if that starts impacting each other, we may have some complication. And this is something we do need to think about. So the existing, like I think from long-acting CAB and long-acting LEN, whatever data is available suggests that this is not going to be a challenge. I think the one thing we should remember with both these agents, especially with people who inject drugs, when you're transitioning to low and middle income country settings, including Ukraine and other parts of the world, is a high prevalence of tuberculosis. We do not have anything besides rifampicin or rifaburin or rifampin, and all of them have a strong drug-drug interaction with long-acting CAB and long-acting LEN. So that's something we need to think about and consider in scaling up this globally. The next thing we really need is efficacy data in humans. We need phase 3 trials. Yes, phase 1 trials are great, phase 2 trials are great, but we really need phase 3 trials. And if we're pretty certain that they can't adhere to oral medications, then let's think about unbalanced allocations where we do a 2:1 allocation where 2 people get randomized to the long-acting and 1 person, but we really do need efficacy data. We have high incidence among people who inject drugs in several settings globally. So the whole assumption that we can't do phase 3 trials because we don't have incidence really doesn't hold true, in my opinion, among people who inject drugs. And then the last thing we also need to be thinking about is really looking at like the efficacy, but with effectiveness, like almost looking at like hybrid designs, because once you show something is efficacious, there needs to be uptake from the community. So most of our phase 3 trials generally happen in these massive ivory towers. But if you want to work with people who inject drugs, you really have to go out into the community where they live, right? So looking at like integration into the OTP programs and the MOUD programs is something we should look at. Also looking at like field-based or van-based delivery. Like, could you go out into the field, do the screening, deliver the medications in the field? For example, some of these long-acting combinations are stable at room temperature. So could you actually take them out in a van and deliver them? And how does that work? And how does that affect acceptability? I think these are all questions that we should be looking at going forward. And it's not just people who inject drugs. I think stimulant use and non-injection drug use also has a huge role with PrEP. There was a lot of evidence earlier that said that people who are engaging in stimulant use have like poorer outcomes along every step of the PrEP cascade. There was also hesitation of providers to prescribe PrEP for people who are reporting non-injection drug use. But these are some data from the PATH PrEP trial in Los Angeles, where they actually, so on the left, it's like condomless sex with 1 partner or no partners. On the right, it's condomless sex with 2 or more partners. And so you can see that on the right panel, there is a lower coverage of acceptable PrEP concentrations among stimulant-using population, but sort of like catches up over time. And in most of these groups, PrEP efficacy, predicted probability of PrEP efficacy coverage goes down, except for that one group on the right, which is the stimulant-using people who are having condomless sex with 2 or more partners, where it goes up. Again, these are self-reported data, subject to bias, small sample size. I think something we should consider going forward is whenever we do these trials, using standardized validated equipment surveys like the ASSIST to try and quantify what is the prevalent stimulant use in these different populations. And something that's also worth considering is like testing some of the stored specimen for like cocaine, fentanyl. So you get a sense of like, even in like HPT and OE3, for example, I'm guessing there are some people who were using drugs in that population and may not have reported it or disclosed it at baseline, but it gives you a sense of like, is that the group where the efficacy was lower or was the efficacy not impacted? Yes, it's not going to be perfect and statistically significant data, but in my head, like some data is better than no data. So PrEP is really the first step. And as I mentioned, antiretroviral therapy is probably just as important, even more important, because it actually does improve survival of the individual taking antiretroviral therapy itself. And why ART? Because let's look at HPT and 074, which was like a statistically significant finding where the intervention worked. Viral suppression was only 40% at month 52. And that is just unacceptable. We should be looking at strategies to get that suppression up to like 90, 95%. So there is some data from San Francisco, from Ward 86, that has showed that among substance-using populations, long-acting cabotegravir and long-acting rilpivirine was able to get the viral suppression up to 97%, even when they had detectable virus at baseline when they started it. So again, this is something we should be thinking about as we go forward. And why are we not moving outside of the traditional populations whom we work with in all these phase 3 trials. And the same thing applies to stimulant-using populations. So the purple line shows you where viral suppression among stimulant-using populations in the SCOPE cohort in San Francisco is. It's lower, it takes a long time. It definitely has improved in the test and treat era, but it's nowhere close to the 90-95% that we want to see. So trying to figure out what strategies can we use, long-acting PrEP, can we use field-based delivery or other complications, really making it more patient-centered and client-centric is something we should be thinking about going forward. So these two really address HIV, but I think what we also need to remember is we need to address the substance use as well, right? Because we know that management of substance use improves quality of life, gets people back into work, gets a lot of people back in their homes, accepted by their families. And so we really have to focus on substance use just as much as we focus on everything else. And I think these are all the different things. And I'm really excited that Narcan or naloxone is available over the counter in the US. Hopefully it's going to be available over the counter globally soon. And that is something that we should remember is the goal of these programs should not be to prevent HIV, but really to improve life, improve survival, improve quality of life, because that really is what programs should be designed to do. The two things I do want to point out is like pharmacotherapy. So we do not have anything approved for stimulants, and we still stick with buprenorphine and methadone, but there are new formulations in the market. For example, long-acting buprenorphine. It has been shown to be extremely efficacious compared to placebo in keeping people free of injection of drug use. But the question is like, how do we translate this into people who inject drugs globally? And this may actually be a PrEP agent. If you can get people to stop injecting, effectively you are preventing transmission. So not only are you preventing HIV, but you're actually having all these other social benefits. And so this is again something which I think as advocacy groups, we should be looking at is like, how do we push these other strategies forward? And the one other thing I want to point out here is we treat opioids with opioids. For example, we're treating heroin use with buprenorphine, but we shy away from treating stimulants with stimulants. And in fact, that's where the data is strongest. So this is a double-blind randomized control trial where people who were using cocaine were randomized to either to a placebo, immediate release amphetamines, or sustained release amphetamines. And you could see that at week 8, the people who were randomized to the sustained release amphetamines have like a much higher probability of being cocaine-free tests in the urine. And again, repeated with methamphetamine salts. And so there is this data, but we just get very nervous about talking about treating stimulants with stimulants. The study on the left in the bottom is among people who had ADHD and cocaine use. And so what this trial essentially showed is like by randomizing them to get extended release methamphetamine salts, either at 60 milligrams or 80 milligrams, improved both ADHD outcomes and cocaine-free urine screens. So there is this benefit. But really the strongest intervention we have to date for stimulant use is contingency management and conditional cash transfers. And you can see like in all those different approaches, anything on the right side of that dotted line is a good thing. Anything on the left side, no effect. Anything is a bad thing, and anything that overlaps means it really is no effect. So you really can see that most of those things with contingency, the top 5 rows, all of them are towards the right. And so it is something we need to think about is like, how do we start scaling up contingency management to be a routine standard of care when working with people who are using drugs, especially stimulants and methamphetamines and cocaine. And last but not the least is we need to take the whole health approach, because we need to recognize that there are these socio-structural determinants that really are defining health. So we need to figure out how do we address all these different things at the same time as everything else. And I just want to end with this, because I think the way we think about these strategies is we think of them separately. For example, PrEP is probably done by the HPTN, ART is probably done by the ACTG, substance use is done by the Clinical Trials Network, and health, I'm not quite sure who really is doing. But what we really should be transitioning is like figuring out how do we actually work together across these networks and across these people to come up with these status neutral whole person approaches, because that really is the future. Right? And we also need to make sure that we don't end with a publication in a journal, but it really translates to impact lives globally. And if you ask me, that really is the impact factor we should care about and not the impact factor of the journal. So I want to end by just saying 2 things. And I think the first thing I want to say is if we are really serious about ending the HIV epidemic, achieving HIV/AIDS epidemic control, the UNAIDS 95 targets, we need to pay just as much attention to people who inject drugs in the US or Ukraine or India as we do to heterosexual women in sub-Saharan Africa or cisgender men who have sex with men in the US, because otherwise we're never going to get there. And I think the second thing I want to say is that we need to start asking the hard questions. Yes, this model that I'm proposing of a status neutral is hard, but how do we do it? Because we really need to be doing transformative research and not something which shows you an incremental benefit of 5% or 10%. I want to thank the different people who helped me with this, and thank you for your attention.
Thank you so much, Sunil. Can people hear me? Can you hear me?
Yes.
All right. Sorry for my earlier AV problems. We will take a few quick follow-up questions for Sunil, and we will share all the rest of the questions for once Dr. Khaliva is done with her remarks. Shakir, I see you have your hand raised. Would you like to come on camera and ask your question?
Sure. Thank you.
Go ahead.
Hi. So, thank you for this, and I appreciate everything you've had to say. So one thing I've kind of rediscovered is the idea that drinking alcohol leads to more risky behaviors. So how can we put that message out there to young adults, because they are likely to access it and then have more risky behavior, which creates, I feel like, a cascading effect. Again, they're going to encourage other ones to do the same thing. So how do we stress the importance to the young ones, or how do we campaign that? Because we know through evidence that it leads to more risky behavior, which, you see what I'm saying? So how do we preemptively jump and attack it in that way?
Thank you,
Thank
Shakir.
Shakir, that is a great question. I agree with you 100%. I know I did not mention alcohol use in there, but alcohol use is just as important to address as meth or cocaine. I think the challenge really is like figuring out how do we reach these populations, and this is a global issue, right? And I think Jim led the PrEP for Love campaign, and so he really has figured out how you reach these populations. And if you ask me, I would say we need to start targeting social media and getting the message out there, because if you look at adolescents these days, TikTok, right? Instagram Reels. I don't know if I'm mixing things up. I don't do either of them. I do Instagram, but I don't know what the Reels and the YouTube has like their own version of it. That's where these adolescents are at, right? And so it needs to be something that they can relate to. So almost building like case studies where adolescents are giving their own challenges and what happens. Maybe that is a good place to start, but really reaching outside the traditional, because none of the adolescents are really using television anymore. They're all on their phone. So we really need to figure out how we get there. And I'm wondering if Jim has like any thoughts on that.
Just wanted to say, the music, the music talks, it literally tells the kids what to do. It's almost like drink the alcohol, have the sex. You see what I'm saying? So, we really need to address it there, because, again, the music gets all around the globe as well. But thank you.
Thank you, Shakir. And, just thinking about social marketing, Sunil, there's one more question I'll have you answer, take on before we move on to Dr. Khaliva. But are you aware, Sunil, of any social marketing efforts that focus on PrEP and people who use or inject drugs?
I am not 100% certain. I know that in our program in India, we're trying to target MSM or engaging in chemsex through these platforms, but not necessarily people who inject drugs. I am not 100% certain of that. And so I would say I don't know is like the most appropriate answer there.
Yeah, and I'll just say, I've done some social marketing on PrEP, as Sunil mentioned, the PrEP for Love campaign, which included gay people and straight people in that campaign, and transgender individuals of all sexualities. And I'm working right now on a campaign focused for teens, but I've personally not seen anything that focuses on people who inject drugs and PrEP. So if anyone on this call knows of anything or wants to share some links, can point us to some examples. I think there's a real paucity of this sort of material. I'll also just say, you know, with regard to some of the conversation around reducing use or quitting use, I think those can't be our only strategies. People will use drugs. People have used all kinds of drugs since the beginning of time. We will be using drugs until the end of time. So I think we have to think about harm reduction. We have to think about ways that people can use the drugs that they want to use and help them stay safe and healthy. So I think we need to remember that people use drugs for all kinds of reasons, and we're not going to get them to stop using drugs. I'm using a drug right now. It's called caffeine. I also use cannabis on a regular basis, and I have no intention of stopping. And I think, you know, we need to remember when we're thinking about people who use and inject drugs that there's all kinds of reasons people do this. And if we can help them with their behaviors stay safer and healthier, that's a goal. It's not always about reducing or quitting. Dana, I see you have a follow-up question, then we're going to move on to Dr. Kaliva.
Yeah, and I don't know if this is too far off what we've been talking about, but I just want to throw it out there as a consideration at least. Over the years, we've talked a lot about drug and alcohol use in regard to sexual behavior and inhibitions, yet it doesn't seem like we've talked a lot about sexual arousal being involved in decision-making also, because at least a lot of people that I've talked to over the years, their decision-making tends to be not as responsible when sexually aroused, especially for younger ages. And I don't know if there's research. I haven't done any looking into that to see if there's research that talks about that thoroughly, and how many people who run into HIV infection have not used any sort of substance, but because of sexual arousal, their decision making is not as I don't know, is more risk taking. That's the word I'll use in this situation. It's more risk taking than it would be if they weren't sexually.
Yeah, I think you bring up a good point about arousal, and I think that's one of the Achilles heels, right, of condoms, is that condoms need to be deployed, especially male or penetrative condoms need to be deployed at the height of arousal when we're not always thinking with all parts of our brain. And that's one of the beautiful things about PrEP, is that it separates the prevention activity from the arousal. So you take your PrEP, you get your shot, you take your pill. When it comes time to have sex, it's divorced from that, and you're ready to go and ready to enjoy a wonderful sexual encounter. So I think we definitely need to have more things, more choices for people that fit into their lives, and that could be injections, that could be pills. I'm really excited about rectal douches, frankly. So people who have anal sex use a douche to clean out in advance. You add some drug to that it provides prevention. They're getting the hygiene and the prevention they want. And when it comes time for sex, they can be out of their head with arousal. They can be having a wonderful time, completely not thinking about HIV and having the protection they need. But great comment, Dana. Thank you. We are going to move on and invite Tatiana Kaliva to join us by video and share your remarks. Tatiana, are you there?
Так, доброго дня. Мене чутно?
We can hear you beautifully. Thank you. Go ahead.
Доброго дня. Мене звуть Тетяна Калєєва. Я працюю лікарем в Україні в Одеському обласному центрі соціально значущих хвороб. Досвід роботи в ВІЛ-інфекції вже 20 років. З січня 2021 року я ще працюю лікарем у складі мобільної амбулаторії. Головна мета, головне завдання роботи нашої амбулаторії – це оптимізація виявлення випадків ВІЛ-інфекції серед людей, які вживають наркотичні препарати ін'єкційним шляхом. За цей час ми проводимо консультування, тестування ЛВІН, і при виявленні ВІЛ-інфекції призначаємо антиретровірусне лікування. З жовтня 2022 року в нас активно впроваджена інтервенція щодо призначення ПрЕП, тому що зрозуміло, що тестування, виявлення та лікування – це дуже добра стратегія профілактики ВІЛ-інфекції, але призначення ПрЕП – це допоможе нам проводити профілактику ВІЛ-інфекції серед населення. Наша ключова група – це ЛВІН, а також їх партнери. З початку впровадження цієї інтервенції нашої амбулаторії було призначено ПрЕП 63 клієнтам. З них 97% – це ЛВІН, і 3% – це їх партнери. Наша команда працює преимущественно у місті, і клієнтами є ЛВІН, як я вже сказала. В склад команди входить ще соцпрацівник. Сумісно ми проводимо інформування, консультування наших клієнтів, тестування. Як вже сказали спікери до мене, наші клієнти мають невелику обізнаність, низьку обізнаність щодо ризиків інфікування ВІЛ, вірусними гепатитами. Тому ми максимально надаємо максимальну інформацію і пропонуємо, кажемо о тому, що є ефективний спосіб запобігти інфікуванню ВІЛ, доступ широкий до цього методу, і рекомендуємо призначити ПрЕП. Умовляти пацієнтів, на мій погляд, іменно умовляти не треба. Треба надавати якісну, повну інформацію. І рішення клієнта повинно бути щодо згоди отримання ПрЕП повинно бути осознаним. Ми в цьому можемо лише допомогти. Яким чином? Наші клієнти, як правило, не мають документів, які підтверджують їх особистість. Ми допомагаємо в відновленні. Ми їх супроводжуємо з початку тестування і призначення ПрЕП усі наступні дні. Після призначення ДКП перше тестування клієнта на ВІЛ відбувається через 1 місяць після початку прийому препаратів. Потім через 2, потім кожні 3 місяці. Тобто соцпрацівник постійно на зв'язку з клієнтом, він з ним проводить і інформаційні бесіди, і нагадує про прийом препаратів. Наші клієнти отримують ПрЕП на щоденній основі. Тобто 1 таблетка 1 раз на добу. Утримання і дотримання прихильності, ми проводили аналіз, складає у нас 94%. За цей час, з жовтня 2022 року, було втрачено 4 клієнта, тому що з ними просто втрачено зв'язок. Для нашої групи клієнтів, мені кажеться, що це досить добрий показник. Працювати важко, тому що наші клієнти менш схильні дбати про своє здоров'я. Тому треба нагадувати, проводити роз'яснювальні бесіди. У нас є друковані матеріали щодо ПрЕП, щодо зниження ризикованої поведінки. Також в нашому центрі працює сайт призначення замісної підтримуючої терапії. І ми вже 5 наших клієнтів скерували, і вони вже отримують ЗПТ. Це також покращує, по-перше, знижає ризик інфікування ВІЛ, а по-друге, покращує нашу з ними співпрацю і тісний контакт. Опять же, з метою дотримання і утримання в прийомі ПрЕП. Тобто у нас комплексний підхід до роботи з нашими клієнтами. І призначення ПрЕП – це дуже гарна опція для профілактики ВІЛ, для зниження ризиків інфікування ВІЛ серед групи наших клієнтів. Якщо є запитання, то я з задоволенням відповім. Попитаюсь відповісти.
Thank you very much, Dr. Kaliva, and sorry for folks who had some challenges with the interpretation. There is a world icon at the bottom of your screen. That's an interpretation icon. You need to choose the language you want to be hearing the content in. You will either choose English or Ukrainian. And Stas and Dmitry, we have a follow-up question in Ukrainian in the chat. Would one of you like to read that question in English and pose it to Dr. Kaliva?
В мене переклад включен.
Thank you,
Yes.
Stas. We did hear.
94% утримання. Як ми відстежуємо відданість? По своєчасному вони звертаються або до центра, або на мобільну амбулаторію для отримання препаратів. Своєчасне звернення ми видаємо, ми знаємо кількість таблеток, які ми видаємо клієнту, і знаємо, коли він може раніше до нас звернутися, але не пізніше цього сроку. Тобто один із маркерів – це своєчасне звернення до нас для отримання препаратів, своєчасне звернення для тестування. І також під час зустрічі з клієнтом ми обов'язково задаємо питання, такі перевірочні або допоміжні для нього. У котрій годині він приймає препарати, не забуває ли він їх приймати, а щоденно ли він їх приймає. Ну так, щоб ми могли розуміти, наскільки по правильності відповіді клієнта, наскільки воно відповідає істині. Є питання, наскільки зменшився рівень інфікування ВІЛ серед клієнтів. Серед наших клієнтів я не можу сказати, бо ми призначаємо ДКП ВІЛ-негативним клієнтам. Виявлення ВІЛ-інфекції серед нашою командою, він став менше. Це не є результатом праці тільки нашої амбулаторії. ПрЕП призначають і усі заклади нашого регіону та й України, які надають послуги ВІЛ-позитивним людям, а також неурядові організації. Но загальна кількість випадків ВІЛ-інфекції в регіоні зменшилась.
Thank you, Dr. Kaliva, and thank you, Stas, for your help there. Oh, is there more?
Є ще питання, як програма досягла 94% утримання. Все-таки це завдяки співпраці соцсупроводу клієнта. Тому що соцпрацівник буквально кожного тижня з клієнтом контактує. І мені здається, що це також дає свої певні результати. Тому що тільки видати препарати клієнту, йому все розповісти і відпустити його аж на місяць, сумнівний можемо отримати результат. Вони можуть забути ці таблетки, вони можуть утром вийти із дому, не знають, де вони окажуться ввечері, чи вернуться вони додому, чи ні, де вони будуть завтра. Ми можемо їх не знайти. Соцсупровід, мені здається, це дуже допомагає в утриманні клієнтів на ПрЕПі.
Thank you so much. Thank you for that. Giannis, I see you have your hand raised.
Yes, thank you, Jim. I just wanted to say to Dr. Tatiana, congratulations for all your efforts, your heroic work to your clinical team and social workers operating in Odessa. I think it also speaks to what Tatiana noted. The investment that's required, obviously, in providing differentiated service delivery, but holistic support. I think this was also echoed by Sunil. And I think there's also the obvious recognition that the impact that the war is having also and will have long-term psychologically across the country. And obviously, despite the efforts of scaling up treatment, we're very good in Ukraine in terms of our third 90. We still have to ensure that we are expanding the HIV testing network. We've had over 10,000 people that have been offered oral PrEP. We're about to introduce long-acting cabotegravir, but in limited numbers under a small pilot. Nonetheless, I think there's still kind of a recognition that things may get harder before they get better as far as the impact that the war is having on communities. So obviously, there's the psychosocial support as a key element of PrEP delivery, cannot be understated. So again, I just want to thank Tatiana and to your whole team, and thank you for being with us today, operating in the most difficult of circumstances. Thank you.
Thank you so much for those remarks. And I think we also, all of us here on the webinar who are not in Ukraine, send you all the love and support and, best wishes for, we know you are going through some very tough times, and the work you're doing, Dr. Kaliva, and all your colleagues is really quite extraordinary. Already very hard work, and doing it in the setting that you are doing is really quite incredible. Thank you so much for taking time to share your story with us here today on the webinar. This is a question for all our panelists, and John, if you would like to come on camera, we'll add you to the spotlight here. But it came up for me too when we were talking earlier, but this is a question from Jen. And she asks, how do we change the perception among sponsors or researchers to include people who inject drugs and use drugs and stop putting people in boxes? I work as a research nurse in HIV vaccine studies, and this is something I see often. And it really just strikes me, cisgender women are also people who inject drugs. Sex workers can be gay men. Gay men can inject drugs. Like, none of us are sort of these distinct, very discrete identities. So what are your thoughts, Sunil, and others on how we can break these boxes and make sure that as we do that, we are inclusive and including people who use and inject drugs?
Thanks, Jen, for that question. I think that's something that I have been struggling with. But I think the way we do that is by just pushing back, because I think most studies go through multiple reviews, and I am pretty certain Jim is also aware that in the ACTG and the HPTN, there's like a lot of community groups that review protocols. And I think when we're reviewing protocols, the question we should ask ourselves is, why are we excluding A, B, or C? Right? And really trying to understand, like, is there like a scientific rationale for excluding them? Or are we excluding them just because we've been doing it for 20 years? So let's do it for 20 more and no one's really going to notice. Because I think that's really what has happened, is like, we generally cheer, from every time I've spoken to people, the reason people want to exclude substance using populations from phase 3 trials is, oh, they're hard to follow. They're hard to retain. We're going to lose data on these people. And that's generally been that focus. And so the problem is, because of that, we never actually get any trials going. So I think the way we make it happen is all of us push together. So we need to push from the advocacy side, we need to push from the scientific side, and really come to that point where we make people recognize that we are not going to solve this problem if you exclude a particular population, and also making them recognize what I said earlier and Jim repeated is, all these boxes we're creating are artificial, right? And we don't know how to interpret. Like, if you ask me, is long-acting CAB going to work in men who have sex with other men who are also injecting? We don't know because they were excluded from the trial, right? So I think it really is getting to that point where we need to push back. And I think it's possible. I think people are listening. They are, after all, think about it. Like, I think many years ago, like, we weren't including as many people who were assigned female sex at birth, or making sure we have minimal racial numbers, like making sure we have so many colored people in the trial, making sure we have so many gender diverse people in the color. And all this has happened because of advocacy groups. So I think we just need to push to make sure that that next thing should be like, we should also make sure that these trials have some number of substance using populations as well. I hope that helps answer, Jim, but I wish I knew the answer.
You're right. I mean, I think, you know, it won't happen without a lot of noise from community constantly pressing. And you mentioned gender diverse folks. I mean, for many, many years, transgender men and transgender women were excluded from studies, and they were excluded for the same reasons you mentioned. Oh, it's challenging, it's difficult. You know, the biology makes things confusing and it's just too hard, so we're not going to do it. And for years and years and years, we ignored trans people, and we've really ignored trans men a great deal. And it's only recently that we've started to, you know, turn the dial on that and start being mindful of including these folks. And regardless of the challenges or the difficulties, they're human beings and they deserve to be included. And we're not ending anything without them part of it. So I think we need to definitely take those same lessons for people who use and inject drugs and really push on that, because it's not going to happen without us making a lot of noise. I don't know, John, do you agree with us on that? John Kimani?
Yes, I totally agree with you, Jim, and thank you to all the presenters. Tatiana, you have our support, and in solidarity from Kenya and East Africa. We know you are going through a lot, and we would love to support in any way we can, but you are in our hearts and prayers. Well, Jim, I totally agree. I think when it comes to the issue of people being excluded rather than being included, we had this motto that we lived with, that nothing for us without us. And as we continued moving away in trying to look at different data, different interventions, and when it comes to data, sometimes you find that is where the problems comes up. So if we are not able to collect the right data on men who have sex with men and also inject drug use or inject drugs, if you're not able also to be able to like make it very clear that female who sex workers who also use drugs, if we are not able to get that data of use drugs and is collected as one, which is FSW, then we will continue missing out numbers and data on women who use drugs, on men who have sex with other men and also inject drugs. So I think it is very important, and I think this is something that should go across all the FSW and also MSM and other key population typologies, that to make sure that we collect the right data, make sure that we refer these people to the right services or to the right organizations that will cover their other services. Something else is that we can say there has been minimal support when it comes to funding or supporting resources, because we are underfunded as networks of people who use drugs. There's a very big gap because also reaching out to our communities, it might be challenging because you find that we go back into hiding in the using sites where you find that a lot of people are not able to access those places. It is only their peers that are able to access those spaces. So I would urge, as there has been continued support amongst people, MSM and FSW, we would also kindly request that donors also make it a priority in also funding people who use drugs, so as we are able together to tackle and prevent the continuous and new infections amongst people who use drugs and general population. Thank you, and over to you, Jim.
Thank you so much, John. Sunil, you mentioned early in your talk about the CDC guidance and the updated guidance for PrEP. Can you just remind us and clarify what the CDC guidance says about oral and injectable PrEP for with regards to people who use and inject drugs?
So only oral PrEP is recommended as per, because long-acting CAB was never even done. So for oral PrEP, there was that one trial in Bangkok, which was the TDF Bangkok trial. It wasn't necessarily active injectors. I think less than 30 or 40% of them had injected in the prior 3 weeks. It was a lot of people who were already in. So, but the recommendations are oral PrEP for people who inject drugs. So that's what it has in the latest guidelines. And I think that brings up, there was another question, if I can just go ahead and answer that, is like,
yeah, feel free.
About HIV incidence among people who inject drugs on PrEP. I think we don't know. We don't have that data. The only thing that we have is from that PrEP trial where it was 0.3 per 100, 0.3 or 0.34 per 100 person years. So it was pretty low in that trial. But as I mentioned, that trial already was enrolling people who inject drugs who were enrolled in a methadone maintenance program. So they weren't really actively injecting when they were enrolled into that PrEP trial.
Thank you, Sunil. And there was another question, and I'll take it, and then if you all want to jump in and expound, if you feel the desire. But there was a question on whether the makers of long-acting cabotegravir that we're using for injectable PrEP right now, are they interested in people who inject drugs as a population? And I would say, I mean, when they did the studies, they didn't include people who inject drugs, so they weren't super interested then, and we're not seeing a whole ton of interest in folks doing PrEP studies, including people who inject drugs and use drugs. That's why we're really doing this webinar, to call attention to this lack of interest. That's very problematic. This person who asked the question also just notes that their sense is that the current plan for injectable PrEP or injectable cabotegravir as PrEP is really focused on high-income countries and places where governments or insurers can cover it. I would agree with you, and I would also say even in quote unquote a high-income country like the United States, it's very, very, very hard to access injectable PrEP, even with insurance, even with programs. There are lots of barriers, and a big barrier to this drug is its expense. It's incredibly expensive. It's more expensive than name brand Descovy for PrEP, which many aren't using anymore. We can use generic Truvada in the United States, but drug prices are a huge barrier. And I just want to also take my bully pulpit to say it really gets me. It makes me really angry that the drug maker makes this drug so expensive, particularly in the United States. We pay the highest drug costs of any country in the world. And our US taxpayers help pay for those studies. We help pay for HPTN 083 and 084, the thousands of people who tested long-acting cabotegravir all over the world and showed it worked. So we put in hundreds of millions of dollars from our taxpayer coffers, And then we get hit with the very highest costs to pay this. And it is very hard. It's very hard on our system. And, you know, when pharmaceutical companies are at the top of the heap, a lot of us end up losing. I don't know if you want to say anything to that, Sunil, but I needed to have my little moment there.
If I can just add like 2 or 3 quick points. So
Yes.
I like to believe that when when the company that makes long-acting cabotegravir did the animal trials and looked at intravenous challenge, there was a plan to look at people who inject drugs. And I do believe that there are some proposals in the pipeline and some demonstration projects being planned, but I don't think anything has actually come to fruition yet. But that being said, in terms of access, they have signed under the MPP, so there are going to be generic versions of long-acting cabotegravir available in over 100 countries globally. And I think that would actually improve access. You mentioned the challenges in the US. I completely agree and hear you on that. But I think it does improve access to long-acting cabotegravir globally and also gives us the opportunity to do the trial with long-acting cabotegravir in a generic version outside of the US. The only trial that I know of, the only reason is because I'm involved in it, is like there is a phase 2 trial of long-acting lenacapavir, which is among people who inject drugs, but that is restricted only to the US. So there is some happening, and I think if we all work together and continue our advocacy and push, I'm pretty sure we can make sure that we start getting long-acting CAB and long-acting len and any other new regimens out there.
Thank you for adding that really important context. I appreciate it, Sunil. I see we are getting towards the end, but I see Alexis with their hand raised. So Alexis, we're going to give you the last verbal question. Please make it brief so we can have time to answer.
Oh, sure.
Oh, we heard you for a second and now you seem to be muted. Our people, oh, we heard you like you said we heard something and then you went away. I'm so
Sign
sorry.
language is what we should.
Well, let me see.
You're back. You're back.
Oh, there you are.
Great. So I'm just happy to report that we've been able to partner with Prevention Point here in Philadelphia to offer long-acting cabotegravir, in part through a study funded by NIDA and another funded by ViiV, which is the manufacturer of INPUD. And we've been tracking rates of uptake and reasons rationale for which form of PrEP they've been choosing. And uptake of cabotegravir has been hand over fist higher, with, I'm going to guess, upwards of 80% of our very small 50 women sample choosing that modality. And retention rate has also been very, very high, but we're using a variety of forms of contingency management to encourage them to stay on their PrEP. As soon as those data are available, we will look to share them broadly. And Jim, if there's a way for me to share some of those data, as well as some of the resources that we've put together to educate women about PrEP with the rest of the group, I'd be happy to get that to you as soon as possible.
That would be great. Thank you, Alexis. You can send that to me if you're on the Choice Agenda listserv. We would love to see it there. But if you're not on the Choice Agenda listserv, you can send it to me and I'll share it widely as you'd like. Love to get this information out. So thank you for that. We are at time. I want to thank everyone for joining us today and thank you for bearing with us for some of these AV challenges and speaker challenges. It's always an interesting day when we have a Zoom webinar. You never know what's going to happen, but I appreciate everyone's patience and forbearance. Again, much love and respect and everything. Good juju to our colleagues and friends in Ukraine. Thank you, Dr. Kaliva, for joining us. Thank you, Stas and Dimitri, for your excellent interpretation always. Thank you, Giannis from WHO, for always being such an amazing advocate for Ukraine and making sure we hear from Ukraine and we don't forget about Ukraine during these very, very challenging times. And we hope to see these challenging times end soon. I'm sure everyone here agrees with me on that. I want to thank Sunil, Dr. Sunil Solomon, from Johns Hopkins and John Kimani from Kenyan Network of People Who Use Drugs for joining us. Thank you so much for your wisdom and your remarks today. Thank you for our colleagues at the International Network of People Who Use Drugs for helping put this together. And again, to my good colleagues at AVAC who helped me think this through, both Muko and Annette. We will be sharing the recording and the slides with you. Everyone who is registered will get an email letting you know when they're available on the website. We'll also capture all of the resources that have been dropped in the chat, and we will put those into a resource document so you can go back and check those out. If you have other resources that you would like to share, please send them to me. You've gotten enough emails from me being on this webinar, so you can respond and send me whatever you might have. We can include that. And finally, I look forward to seeing you all in a month when we're going to be talking about doxy-PEP and implementation and how that's going so far in the United States. But I do hope that this topic, focusing on people who use and inject drugs, that we will have more time to talk about this. I would be very keen to do more webinars on this topic and highlight the needs and highlight the issues and help break down these boxes that we put people in and ensure that all folks who are interested and desire options for prevention are included in our research and are included in our programming. Leaving anyone behind is not acceptable, and we need to have a strong voice to change that narrative. So with that said, I want to thank you all again for joining, and I wish you all the best day, afternoon, evening. Some places it may be tomorrow already. The best of all of that to you, and we will see you on the other side soon. Take good care.
Thank you so much, Jim, and everybody. Stay well and safe.
Thank you.